Hi guys, welcome to the 8th podcast of Let's Revise MBBS Cardiology, and today we'll be talking about coronary artery disease. Okay, so this will take around 2 to 3 podcasts to complete, and today we'll mainly focus on atherosclerosis, chronic stable angina, and then the drugs used in angina. Okay, so coronary artery disease is also known as ischemic heart disease. So it is a condition in which there is a blockage in one or more arteries supplying the heart, and this leads to decrease in perfusion and ischemia of the heart muscles. Okay, most common artery involved is left anterior descending artery. Okay, LADA. Now let's talk about atherosclerosis. So risk factor for atherosclerosis can be divided into modifiable risk factors and non-modifiable risk factors. The most important modifiable risk factor is smoking. Other modifiable risk factors are hypertension, diabetes, and intake of trans fatty acids. And non-modifiable factors are male gender, type A personality, and increase of homocysteine in blood, that is homocystinemia. Right? Now pathogenesis. So the most accepted pathogenesis or theory is the inflammatory response to endothelial injury. Okay, so smoking, hypertension, and high lipid diet causes high lipid in the blood causes endothelial injury. Because of this, there is monocyte and platelets aggregation, and there is a release of growth factor. This growth factor leads to smooth muscle proliferation. Okay, then foam cells are formed. On histopathology, the earliest finding is of fatty streaks, and the mature plaque consists of a fibrous cap and a necrotic core. The fibrous cap has smooth muscle, macrophage, and some foam cells, and necrotic core has dead cells, lipid, and cholesterol. The complication of atherosclerosis can be that it can rupture or erosion can happen. There can be hemorrhage and there can be aneurysms. Right. Now in CAD, the most common area to be affected, or the area to be affected first, is the subendocardium. Why? Because the blood supply is from epicardium to endocardium, right? So endocardium should be affected more, but the blood which is there in the heart, that blood has enough oxygen to supply the endocardium. So the myocardium just below the endocardium, that is subendocardium, is mostly affected or is most affected. Now coronary artery disease can present as a long-standing chronic decrease in coronary circulation, or there can be sudden and severe decrease in coronary artery perfusion. Okay, if it is long standing chronic, then we call it as chronic stable angina. Okay, and if it is sudden or severe, then we call it as acute coronary syndrome. We will talk about acute coronary syndrome in the next podcast. Okay, in acute coronary syndrome we have STEMI, ST elevation MI, and non-ST elevation acute coronary syndrome. In non-ST elevation acute coronary syndrome, we have non-STEMI and unstable angina. Okay, so we will talk about this in the next podcast. Today our focus will be on chronic stable angina. Okay, so in chronic stable angina, there is no permanent damage to myocardium. It's just ischemia. Okay, and the markers and cardiac markers are also normal because there is no infarction. The features of chronic stable angina are that there is a squeezing type of chest pain which is substernal in location, and it radiates to the arm, it can radiate to jaw, to scapula. Okay, but it does not radiate to trapezius. If it radiates to trapezius, then it suggests that it is the pain of pericarditis, acute pericarditis, right? And the pain usually lasts for around 2 to 5 minutes. If the pain is below the umbilicus or above the mandible, then it is mostly not angina. It is pain due to other thing. Okay, right. So chronic stable angina has a consistent duration, has a consistent severity, and it is provoked by a predictable level of exertion. So that person will tell you, when I climb up 2 floors, then I start getting symptoms of angina. So that is defined. Okay, that is predictable. And the pain is short lasting. It's around 2 to 5 minutes, and it is relieved after nitrates. Okay, after giving nitrates. For investigation, we do exercise and stress test or stress ECG, and there is a protocol which is Bruce protocol. You just need to remember the name. Bruce protocol is for stress or exercise in test. Okay. So if the rest pain is present, normally in chronic stable angina, the pain occurs after exertion. But if the pain is present at rest, then it is a contraindication for doing stress ECG. Okay. So if resting symptoms are present, then we need to go for myocardial perfusion scintigraphy. Okay. If it is resting symptom, if the pain is present during rest, it's mostly not angina, but it can still be angina. So in case of resting symptoms, we go for myocardial perfusion scintigraphy. So in management, we need to assess the cardiovascular risk factors, and we need to aim at reducing the modifiable risk factors like hypertension, smoking. So we need to reduce that, smoking, regular exercise. Okay, these are all the lifestyle modifications. For the treatment of acute attack of angina, sublingual nitroglycerin is given. So what is the mechanism of action of nitroglycerin in stable angina? It reduces preload. Okay. And mechanism of action of nitroglycerin in prinzmetal angina is it causes coronary vasodilatation and increases the blood flow to the heart. Okay. But in angina, in stable angina, the mechanism is not increased blood flow to the heart. It is reduced preload. Okay, this is important. And now for the long-term prophylaxis, we give vasodilators so that the oxygen supply is increased to the heart. So we can give nitrates and calcium channel blockers. And to reduce oxygen demand, we give beta blockers. Okay. Now let's talk about some other drugs used in angina. So the first one is ivabradine. Okay, the mechanism of action of ivabradine is that it blocks the funny sodium channels. Right? Do you remember this? We had talked about this in the first podcast. So since it blocks the funny sodium channels, the slope of the slope decreases. That's why the heart rate also decreases. So it causes bradycardia. So it's in the name itself, ivabradine, bradycardia. Okay. So ivabradine is called a bradycardiac drug. It causes bradycardia without hypotension, just bradycardia. Okay. Side effect is it causes QT prolongation, and it should not be given with beta blockers or verapamil, because even this drug inhibit SA node. So if we give ivabradine along with beta blockers or verapamil, there will be a severe bradycardia. Right. The second drug is ranulazine. Ranulazine has a 2 to 3 mechanisms of action. That is, it blocks sodium channels, it blocks potassium channels, it also blocks PFOX. It is a PFOX inhibitor. But the main action among all these three is that it blocks the sodium channel. Okay. So what happens if it blocks the sodium channel? So the sodium cannot come inside the myocardium, inside the cardiac muscle. So there is another channel which is sodium calcium channel. So if the sodium is not coming in through the sodium channel, the sodium will come in through the sodium calcium channel, and calcium will go out. So sodium is coming in and calcium is going out. Since the calcium is going out, there is decrease in contractility and hence decrease in oxygen demand. Okay, so that's how ranulazine acts. The next is Nicorandal. Nicorandal is potassium channel opener. So because of this, it causes vasodilatation, it decreases preload and decreases oxygen demand. Side effect can be hypotension. The other drug is trimetazidine. Okay, trimetazidine is a PFOX inhibitor. So PFOX is partial fatty acid oxidase. This enzyme is used for using up fatty acid for energy, right? But the problem is when the heart muscle uses fatty acid as its main source of energy, it requires a lot of oxygen, right? So if we give PFOX inhibitor, the heart muscle is forced to use glucose as its energy source rather than fatty acid. So if it uses glucose as its energy source, the oxygen required for glucose is lesser, for metabolism of glucose is lesser. That's why the heart can get sufficient energy even with a lower amount of oxygen. That's how trimetazidine acts. And the next drug is Fasudil. Fasudil is a Rho kinase inhibitor. Okay, so these are the drugs used in angina. Now let's say a patient comes with angina. We give him sublingual nitroglycerin. Okay, so we give 3 tablets within 20 minutes. Okay, the dose is 0.3 to 0.6 milligram. So even after giving 3 tablets, if the symptoms are not resolving, then it is not chronic stable angina. Then it suggests that it can be unstable angina or non-ST elevation MI. Okay. And one limitation of nitroglycerin is tolerance. So for this, we need to keep nitrate free interval for around 8 to 12 hours daily. Right? Since for chronic management, we are going to keep the patient on nitrates, right? So for this, we need to give a 8 to 12 hours nitrate free interval so that tolerance does not occur. Now some one-liners. DASH is the only anti-anginal drug that has shown to prolong life in post-MI, after myocardial infarction, which is the anti-anginal drug which has shown to prolong life. It is beta blocker. Okay. DASH drug prolongs exercise duration and time to angina. That is ranulazine. And ivabradine is what is the mechanism of action of ivabradine? It inhibits funny channels and decreases heart rate. So the nitroglycerin is the first line drug. Beta blockers, ranulazine, ivabradine, Nicorandal are second line drugs, and calcium channel blockers and trimethylamine are the third line drugs. Okay. Now prinzimetal angina. What happens in prinzimetal angina is vasospasm. So it is also known as vasospastic angina, and rest pain are present here. Unlike chronic stable angina, where the pains start after exertion, here rest pains are present, and it mostly present. The patient will mostly have this pain between midnight to early morning. It is associated with sweating, hypertension, diaphoresis. Okay, and it lasts for around 5 to 15 minutes. And this is also relieved by nitrates. Angiography in these patients of prinzimetal angina will be normal. There can be transient ST elevation. Okay, and beta blockers are contraindicated in prinzimetal angina. Right? Now that's it about chronic stable and prinzimetal angina. Now I'll introduce acute coronary syndrome, and then we'll continue it in the next podcast. So chronic stable angina has a fixed occlusion. Okay, and symptoms arise when the occlusion is more than 70%. If this plaque ruptures, there can be thrombus formation. Okay, this thrombus can completely occlude the lumen or can incompletely or partially occlude the lumen. Okay, if it completely occludes the lumen, then it is STEMI, ST elevation MI. If it incompletely occludes the lumen, then it can be unstable angina or non-STEMI. Okay. So in STEMI and non-STEMI, since there is infarction of the myocardium, the biomarkers will be increased. Biomarkers like myoglobin, CKMB, troponin, LDH, all these will be increased in STEMI and non-STEMI. But in unstable angina, there is just angina, there is no infarction. That's why the biomarkers will be normal in unstable angina. Okay, all the features will be similar to the STEMI and non-STEMI. Just the biomarkers will be normal. That's how you differentiate unstable angina from non-STEMI. Okay. Now there are 3 criteria for ACS, and these 3 are symptoms, ECG and enzymes. So if any 2 out of these 3 are present, then we can diagnose it as ACS, acute coronary syndrome. Okay, so if chest pain is present and on ECG we find ST elevation MI, that is also ACS. If chest pain is present and there is on ECG there is non-ST elevation MI or non-ST elevation, then also it is diagnosis of ACS. Then we check for whether enzymes are increased or not. If enzymes are increased, then it is non-STEMI. If enzymes are normal, then it is unstable angina. Okay, right. So that's it for today's podcast, and in tomorrow we'll continue with this. Okay, chalo. Till then, stay safe, stay healthy. Bye bye.